Good evening, everyone. My name is Celine Gallagher, and I'm the Scientific Chair of the Australian POTS Foundation. On behalf of the Foundation, I welcome you all to our webinar series, with tonight's presentation focused on supporting the neurodivergent POTS patient. I would like to begin by acknowledging that we are hosting this webinar from the lands of the Kaurna people. I also acknowledge the traditional custodians of the various lands on which you all join us from today, and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. I'm delighted this evening to welcome Cary Nayda as our presenter. Cary is a health psychologist who operates a small private practice in the Adelaide Hills. Her clinical work is dedicated to supporting clients in navigating the complex relationship between physical and psychological well-being. Cary's primary focus lies in supporting better outcomes for neurodivergent individuals living with chronic health conditions, including POTS, fibromyalgia, and ME/CFS. Drawing from knowledge gained across diverse health settings, Cary's commitment to this area is augmented by their personal experience of dysautonomia and neurodivergence. This amalgamation of professional insight and lived experience fosters a multifaceted approach to their clinical work. Beyond clinical work, Cary engages in health promotion activities, advocacy, and mentorship endeavours. Their commitment revolves around building awareness, improving healthcare outcomes, and fostering a deeper engagement among fellow healthcare professionals in this domain. As a board-approved supervisor and clinical title holder at the University of Adelaide, Cary seeks to improve the development of future psychologists through delivery of clinical lectures and field placement opportunities. We're very delighted to have you this evening, Cary. Thank you very much for joining us. Just a reminder before we do start this evening's presentation that this webinar is being recorded, and a link will be sent out to everyone following the webinar to view at a later date. If you have any questions, please submit these via the Q&A button, and we will aim to get through as many as we can at the end of tonight's presentation. Over to you, Cary. Thank you.
Thank you. I will just get my slides up. Excellent. Can everybody see my slides? That's all good? Yep.
Thanks, Cary.
Yes, excellent. Thank you. So thank you everyone for coming today. It's an absolute pleasure to be able to share with you all. As Celine mentioned, I am a health psychologist. So health psychologists are psychologists that have done their training as psychologists and then have gone on to do additional supervised practice, looking at, I guess, the relationship between physical and psychological well-being. And so very much exploring the interaction between physical and mental health is very much a very big part of what I do in my everyday practice. So thank you, Celine, for already doing an acknowledgement of country. I would also like to acknowledge that, so the Paramount people, so I am actually presenting today from Paramount land, and also the Kaurna people, who are the traditional custodians of the land in which I live, work and play. So just a summary of what I'm hoping to cover today. So I'll start off with an introduction to the language and concepts of neurodiversity. Then a little bit of information just looking at the health status of neurodivergent people. and then step into exploring some of the barriers to healthcare that neurodivergent patients face, and then look at providing some practical strategies that can support access to healthcare for neurodivergent patients. So just to begin with, just a few key definitions. These are definitions that I tend to find that people often get lost and confused in, and they're terms that I will probably be referencing throughout the presentation today. So first of all, the term neurodiversity. So that refers to the concept that neurological differences, including experiences such as autism and ADHD, are natural variations of the human brain. So neurotype then refers to the specific configuration of an individual's brain. So be that being autistic, being ADHD. It's a term that's also used to refer to people living with specific learning disabilities such as dyslexia, dysgraphia, as well as a whole range of other I guess, configurations of neurotypes. So neurotypical refers to individuals who fall within the majority neurotype. And then neurodivergent refers to any individual who has a neurotype that sits outside of that majority. So coming back to things like autistic, ADHD, and a whole range of other neurotypes. And neurodiverse. So neurodiverse and neurodivergent are two terms that often get used interchangeably. However, neurodiverse refers to a group of people, whereas neurodivergent refers to an individual who differs from the majority, whereas neurodiverse is a group of people where there's multiple neurotypes present. So a key differentiation there that people often get confused with. So as I mentioned, so neurodiversity covers a whole range of different neurotypes. And so some of them can be seen under this umbrella. This umbrella comes from Sunny J. Wise, who is a strong advocate for neurodivergence based here in South Australia. As you can see, there's a whole range of different neurotypes that come under this, but today we'll be looking at two key types of neurodivergence, and probably the two that most readily get attributed to the neurodivergent label, so that being autism and ADHD. So just to provide a little bit of, I guess, context for understanding some of these challenges. Autism medically is defined by the DSM. The DSM is unfortunately a very pathologizing book. So this is a slightly tweaked definition of autism, which is described as persistent differences in social communication and social interaction across multiple contexts, as manifested by difference in social emotional reciprocity, differences in non-verbal communication, and behaviours used for social interaction, and differences in developing and maintaining and understanding relationships. So we then move on to ADHD, and you'll see that I've put the disorder in brackets, and I guess that's to acknowledge that for a lot of people living with ADHD and for a lot of autistics, there's acknowledgement that there is both strengths and difficulties that come along with being neurodivergent. So in that space, there is a strong, I guess, rejection of the pathologizing language that's used. And so the term disorder is, I guess, used with caution, but unfortunately something that we have to live with due to the dominance of the medical model. So ADHD presents as persistent differences in attention and or activity levels that interferes with functioning and development. So this can be diagnosed as, I guess there's 3 different ways that it can get diagnosed. So we see what's called the combined presentation. So that's where people present with difficulties with attention and high levels of activity and impulsivity. We also see people who predominantly experience differences in terms of attention and concentration, or predominantly hyperactive or impulsive presentation. So that's the label that's given to people who primarily present with higher levels of activity or impulsivity, but where concentration is not necessarily as big a part of the picture. So within that space, there's also what we see colloquially as ADHD. This is a term that has been, I guess, adopted by the neurodivergent community as a less pathologizing way to describe people who are both autistic and live with ADHD. This term has come about because there is a really high prevalence of ADHD amongst autistics. So the research is really variable in what that shows, but when we look at some of the higher quality meta-analyses, we're seeing pooled estimates of approximately 40% overlap between the two. I guess that combination of presentation or experiences sees unique challenges that need to be recognised. It's a really challenging space, the ADHD space, because until 2014, the DSM, which is our diagnostic Bible for psychological diagnoses, didn't actually allow for both autism and ADHD to be diagnosed together, which has created, I guess, some gaps in the research in how we understand these 2 different neurotypes and the experiences of people who are autistic and ADHD. So unfortunately, a lot of the literature that has been used to put this presentation together focuses on people who have a diagnosis of one or the other. But it's important, I guess, to recognise that people present with often traits of both. And so teasing apart the experiences of people who are autistic and ADHD is not necessarily as straightforward as our diagnostics like to make it sound like it is. All right, so with those backgrounds, just move into a little bit of understanding the health status of the neurodivergent population. Unfortunately, the experience of neurodivergent people is that there are generally widespread poorer health outcomes for this population. The reasons for that is quite multifaceted. But we generally know that there are poorer physical and mental health outcomes for autistic people. Diet and exercise are areas of big challenges. And so with autistic people in particular, we tend to see overeating, undereating, sensory things that make eating difficult, difficulty with sleep, a whole range of lifestyle things that become really difficult for this population of people. We then see with that increased cardiovascular risks, which emerge from these lifestyle factors. And probably most importantly is recognising that autistics tend to find it incredibly difficult to access health services. And that's really important to know because it's something that we can affect change in. A lot of the other barriers, I guess, to health of autistic people aren't quite so easy to fix, but healthcare barriers are something that with a little bit of education and a little bit of flexibility, we're actually able to implement and create a fair bit of change for this population. So of particular relevance for tonight's presentation, it's important to know, and this is the information that underpins why this presentation has come about, is that there is an enormous overlap between neurodivergence and autonomic dysfunction and related conditions. So those that we commonly see being like Ehlers-Danlos Syndrome and hypermobility spectrum disorders. So as you can see, so there's elevated prevalence of hypermobility amongst autistic people. And in the emerging research, it tends to reflect what we see in clinical practice, which is that there are really high prevalence of autonomic dysfunction amongst autistics. And that's something that we have very little knowledge or understanding about at this point in time, but it's certainly something that is important for us to be recognising when we're working with this population. So similarly for ADHDers, again, we have poorer health outcomes across a range of domains. We have lifestyle habits that then contribute further to poorer health outcomes, and also, unfortunately, with ADHDers as well, the increased impulsivity can also lead to higher levels of risk-taking behaviour, so increases in things like car accidents and negative health outcomes because of just engaging in higher risk-taking behaviours. So similarly to autistics, we see increased levels of hypermobility amongst ADHDers. And we also see increased levels of autonomic dysfunction. Again, this is an area that the research is pretty scant on it, but it's certainly something that anyone who works in the clinical dysautonomia POTS space would be well aware of, that there is a huge overlap between ADHD and ADHD is presenting with either hypermobility spectrum disorders, EDS, or autonomic dysfunction. One of the things that I find particularly fascinating is that in the DSM, which we use to diagnose ADHD and autism, is there's actually a section that lists associated clinical features. And so under ADHD, there are features listed such as the high palate that we see in EDS, issues with coordination, and some of the facial features as well that are associated with some of the particular types of EDS, yet there's no reference to the possibility that there's actually a shared link there. It's just something that's just incidentally mentioned in the DSM, but something that's hopefully going to the links hopefully going to become clearer in the future as to why that is. Okay, so as we've seen, there is incredibly poor health outcomes for the neurodivergent population. Again, research is fairly scant as to why this is, but it doesn't, once you start working in the clinical space, some of the barriers become really quite quickly apparent. So I'm hoping to cover some of these barriers today. This is by no means an exhaustive list of the barriers that neurodivergents face when accessing healthcare, services, but I'm hoping that they'll be some of the key ones that will hopefully give, I guess, some insight and some strategies into making services more accessible. I am aware that there are people out watching this presentation who are consumers, and I guess these barriers are, and what I'm about to explore, are things that are more targeted at healthcare providers. But I did think that it could be helpful for consumers, and particularly neurodivergent consumers, to be thinking about these different barriers and reflecting on how they might impact them. And unfortunately, we know that whilst it would be amazing to have healthcare services that are amazingly accessible, unfortunately, it's not always the case. And so I'm hoping that if there's neurodivergent people out there watching this, that this will be an opportunity for them to, I guess, think about what the barriers are that they face, and maybe think about what it is that they need to be able to access healthcare services, with a view that that with that knowledge, that we're better able to self-advocate for what we need in those settings. All right. So starting off with, communication. So to understand the communication barriers that autistics and ADHDers experience accessing healthcare, I guess one of the fundamental theories that it's important to understand is that what's called the double empathy problem. So this was a theory that was developed by an autistic researcher, Damien Milton, in 2012. And he developed this, what's called the double empathy problem, based on a series of research studies where it was identified that the communication breakdown that happens, or what's perceived as communication deficits experienced by autistic people, don't actually exist when we have autistic people communicating with other autistic people. So there was some experiments done where they got a bunch of autistics in the room to communicate with each other. They got a bunch of neurotypicals in a room to communicate with each other. And then they had another condition where they had both autistics and neurotypicals in the room together. Communication went relatively similarly, slightly better actually, in the autistic to autistic condition. Relatively similar to the neurotypical to neurotypical condition, but it was started to be a breakdown in communication when we mix the neurotypes together. And so what Milton brought out of that was that what's, I guess, constructed as deficits in communication is not actually a deficit, it's just a difference in how autistics or neurodivergents communicate when compared to the neuromajority. So from that, he highlighted, I guess, the importance of understanding that this is not a one-sided problem. This is not that autistics don't know how to communicate. This is not that autistics are in some way, I guess, defective. It's that we need to be developing ways that we can actually foster communication, in the same way that if we went to another country and there were cultural differences, we would be trying to find a mutual understanding of how to communicate with each other. We wouldn't be assuming that one or other culture was incorrect. We would be looking for a middle ground and trying to understand things from each other's perspective. So I guess the reason that is important, and particularly important in a healthcare setting, is to reframe the focus of understanding or this idea that neurodivergents are in some way defective, towards shifting the focus of healthcare professionals to finding a way to connect with their clients and recognise that this is just a different way of communicating, and with some self-reflection, we can actually grow and work collaboratively in this space, rather than perceiving that because someone is of a different neurotype that they're being rude or making assumptions about what's meant. So with that understanding that neurodivergents tend to communicate differently, when we compare neurodivergent communication to neurotypical communication, there are some themes that come out. So particularly amongst autistics, we tend to see a quite direct communication style. Often this is perceived by neurotypicals as being rude. Often there is, particularly with autistics, it's what's been said is what's been said. There's nothing more than that. But when we compare that then to a neurotypical, there can be, I guess, a whole lot of assumptions or things that are being inferred. And so when we see neurodivergence and neurotypicals come together in communication, the direct communication style of neurodivergence can be a really big area of breakdowns, because things that are meant at face value. I had a nice one from a client this afternoon that was just a message that just said, "I'm still waiting for my Medicare rebate, full stop." And that wasn't meant to be rude. It was simply a, can you check what's happening with my Medicare rebate? But in a lot of settings, that level of direct communication would be interpreted as rude. There's a lack of small talk. There's a lack of, I guess, some of the fluffiness that goes along with neurotypical conversation. Differences in prosody and tone. So prosody, referring to, I guess, the intonation and pace of conversation, and almost, I guess, the melody of conversation, and tone as well. So tend to see things being either very monotone or, I guess, over-expressive when we compare this to the neuromajority. Similarly, use and understanding of nonverbal communication. So again, that can be either really really expressive or a lot less expressive, and as well difficulties in taking meaning from nonverbal communication. Difficulties with spoken conversation. So a lot of neurodivergents will talk about experiencing shutdowns where verbal communication becomes quite difficult. And we also have a proportion of the neurodivergent population who are completely non-speaking and prefer to use or have a need to use other modes of communication. Things like small talk can be another area of difference. Differences in perception of hierarchies. So I had a really, I did an autism assessment the other day with a young woman who talked about this so beautifully. She just talked about, she made a comment that she didn't like police and she didn't like other authority figures. And when I unpacked that, I had an expectation that could have been to do with traumatic experiences. And she just said, but we're all human, so why do they get the power and I don't? And so those differences in how we perceive hierarchies can really come out in the therapy room when you've got a specialist who's done years of training, and then you've got a neurodivergent person who comes in and has hyper focused on whatever their condition is, and they don't see any, they don't see the hierarchy. So an autistic or a neurodivergent person might come into that setting and quite happily want to engage in a conversation about whatever medical research that they've found, and often for neurotypicals, that can be perceived as a challenging of their experience, when for a lot of neurodivergent people, it's not that at all. It's simply just a want to have a conversation and seeing people as equals. It can also become problematic because when I guess those hierarchies aren't being taken into account, being told that you need to do something by someone who you've just met doesn't necessarily go down too well. And so there can also be some, I guess, challenging of, what right do you have to tell me X, Y, and Z? Can we just have a conversation about this? I want to understand it. And I guess that tendency to see things more equally and take, I guess, a more collaborative approach rather than, I guess, taking as gospel because the doctor said so, that's why I do it. So the next thing in terms of communication is what's called info dumping. Again, it's a bit of a colloquial term, but it's a bit of a tendency to talk about preferred topics. The other things that can impact communication are processing time. So for both ADHDers and autistics, there tends to be slower processing time. So what that means is that it takes extra time to process information being presented to you, which in turn can make conversation quite difficult. So being asked questions on the spot becomes quite complex. And it's really common for neurodivergent people to go into an appointment that's, 15 minutes long, be asked at the end of the appointment, do you have any questions? And it's no. And then, 2 hours later, 24 hours later, 48 hours later, they will then have processed and made sense of the information that's been presented in that appointment, and they will come out with a million questions. And often by that point, it's too late to ask those questions. So that's another thing that can come into play, and that can also then impact reporting of symptoms as well, is just not having the space to, I guess, make sense of what those questions mean, and being asked, do you experience this? And in the appointment saying no, but then, 24, 48 hours later going, oh, hang on a second, yes, I do. Because that's the time that it's taken to, I guess, translate what's been said in that setting, apply it to themselves, and then make sense of what kind of a response is most helpful to give. The last area of communication that I was keen to highlight was the tendency to be tangential, go off on tangents, get distracted by things. Very, very common, particularly with ADHDers. And also, I guess, a tendency to then get lost in the conversation because you've gone off and sort of lost focus. So what can we do to support people around this? So the first point, and one that I'm very keen to, I guess, highlight, is supporting healthcare providers to appreciate different communication styles. As I said, neurodivergent clients are often labelled as rude, as blunt, as in some way inappropriate in the healthcare setting because they're not responding to hierarchies in the way that neurotypicals would. And simply by having an awareness that the assumptions that we bring to conversations may not actually be applicable for the client that's sitting in front of us. And so having the opportunity then to engage in reflective practice and thinking about what assumptions we are bringing to the therapy or the treatment room is really important for us as healthcare providers to make sure that we are not, I guess, unfairly making assumptions about what's going on for our clients. Really important to use direct, concrete language. So autistics and ADHDers can struggle with metaphors, with figurative language. So being really clear to the point is important. Providing summaries of information for reference. So some of that comes into recognizing the differences in terms of processing speed, and difficulties just holding information in our minds can be really challenging. And so providing stuff that people can refer back to and seek clarification on what's been discussed in appointments. Using visuals as well. Just having, I guess, different ways of presenting the information. So not all neurodivergents learn the same, not all neurotypicals learn the same either, but neurodivergents in particular tend to have be quite good at processing visual information, and is often a strength of theirs. And so using visuals to supplement other forms of information can be really helpful. Providing ways for follow-up questions to be asked. So as I mentioned, in terms of processing speed, we often sit a patient down, we go through a whole lot of information and then ask, is there any questions? And then it's job done. For a lot of neurodivergents, that approach doesn't work. And so exploring options that they can follow up, be it at another appointment, be it, so for my clients have an option that they can text me. I know not all practitioners are okay with that, but I have a work mobile that clients can text. Clients know that they can email me, and clients are encouraged to use, note sections on their phones for next time we catch up. So if they've got any questions that come up, so they're given multiple ways that they can ask questions. That doesn't necessarily need to be in the appointment. Offering clarifications, ensuring, so just checking in with clients to make sure they understand, gauging appropriateness of small talk. So as I said, some neurodivergents, quite a lot of autistics in particular, find small talk really challenging. And so when, as clinicians, there might be sort of the assumption that small talk is making a patient feel comfortable. It may actually be leaving some neurodivergents feeling really awkward and sort of out of place and not knowing how to navigate that conversation. So just, I guess, being aware of the person that's sitting in front of you and reading their responses as to whether or not they're being comforted by small talk or whether they're finding this something that's actually quite exhausting and confusing. And the last one I have listed as a helpful strategy is having AAC communication options. This is something that, I guess, depending on the practice or the setting that we're in, can be quite difficult to access. So AAC is basically any alternative way of communicating with clients. So that can look like really different things. I did bring some that I have with me. They're not the greatest. So if people can see, I don't know whether people can see, but I've got some what are called communication cards, which can be used for people who are struggling to use verbally, to engage with spoken conversation. We've also got, so some people will use like an iPad device. And so for those who can see, I don't know how much you can see, but programs like Proloquo give ways that people can communicate using iPad. I quite commonly in session will use chat functions on telehealth. So I use CoView, and so there's a chat function in that, which some clients find easier to access. But even just being able to write notes if people are struggling to use their spoken words as a way of communicating. So just being open to that, even if you don't necessarily have access to the tools. Yeah, just having that as a way of supplementing conversation when conversation is tricky. So next barrier that I've got here is the need for predictability. So neurodivergents will often experience anxiety in new settings, struggle to engage with unfamiliar people, have difficulty with unfamiliar procedures. Irritability with change of plans is quite common. Difficulty implementing treatment plans, because implementing a treatment plan often involves changes to routines. And you might also see a tendency to try and control the settings or how things are undertaken, because the individual might have a preferred way of doing things. So how can we support this? So lots of pre-appointment information can be really helpful to manage some of this. A lot of the time when we're going into medical appointments, and particularly with new specialists, we have no idea what to expect. So just giving whatever information you can. So it might be, you're going into a clinic, you're going to have an appointment with, I don't know, so-and-so, the nurse. That's likely to take half an hour. During that appointment, the nurse is likely to ask you questions about this, and this. You might be asked to do a stand test, something like that. Can just be really helpful in terms of, I guess, providing an understanding of what is going to happen in the appointment, and just alleviating some of that anxiety for the neurodivergent client. Consistency and follow through is something that's really important. Essentially it's if you say you're going to do something, do it. It can really rattle a neurodivergent client if that doesn't happen. Using visual aids and consistent scheduling as just ways of keeping things familiar and preparing clients for different situations and minimizing anxiety. Environmental and procedural familiarization. So that's just so one of the things that I will do for some of my clients will be, I'll send out photos of what the waiting room looks like, photos of the front of the building, things like that, just to create a sense of familiarity before going into the appointment with me. And then also procedural familiarization. As a psychologist, I'm not doing a whole lot in terms of procedures with people or testing or things like that, but particularly with, a first appointment, it's just about, I guess, setting up the expectations of, today I'm going to be asking you a number of questions about yourself. It's a bit of a session of getting to know you, and then we'll be setting some goals or something like that, just to set up the expectations of what's going to happen in the session. Offer choices and opportunities to allow the client to control their engagement. So explaining the whys of procedures, treatments, and interventions. I think this is something that it's very easy for us as healthcare providers to become quite complacent with the interventions that we're doing, that we often forget that the client or the patient is not in that space all day, every day, like we are. And so just providing a little bit of background so that things are familiar, and a little bit more, I guess it's just more just an understanding of why something's going on can help just alleviate some of that anxiety. And the last point on that is offering transition support. So invariably, when we work with patients, there comes a time that we either discharge them from our service, or we might need to refer on to someone else. And so in that offering an opportunity. It might be a 5-minute touch base of, can we have a 5-minute conversation together with whoever it is that I'm going to refer you to, so that just to create that sense of familiarity before you refer them on, or providing ample warning that they're going to be discharged. It's not just that they're coming in for an appointment and suddenly you're saying to them, well, I'm never going to see you again, and off you go on your merry way. So it's just some things around predictability. Next up is sensory processing. So I think we often, when we think about sensory processing, we think about the obvious things. So we think about visual systems, so, bright flashy lights. We think about, noises and things like that. Probably the three that often get overlooked is differences in terms of the vestibular system, so the way that we detect force and pressure. Differences in terms of the proprioceptive system, so balance and motion, and also in the interoceptive system, so being the way that we detect internal bodily changes. So these are all areas that for neurodivergence they can experience hypersensitivity to these areas or hyposensitivity. So this can have a huge impact when accessing healthcare services for a whole range of reasons. And particularly when we think about things like interoception, when we're stepping into a setting where we're expected to report symptoms, if interoception is an area of difficulty, reporting those symptoms can be really difficult. And so that can be really frustrating, and it's not uncommon for me to experience patients who, you'll ask a couple of questions about a whole lot of things and they'll be like, no. And then they'll come back, 3 sessions later and be like, I never noticed that I had palpitations, or I never noticed that, this happened or that happened. And often all that they had been previously able to describe was that they didn't feel good, or they felt anxious, or they felt overwhelmed. And there's just very little ability for some neurodivergent people to actually break down what that means. So a really big thing that can then impact engagement with healthcare services. And the other thing, which I guess falls under the hypersensitivity to sensory input, is being mindful of sensory overload. So I think when we talk about sensory input, we might think about what happens in the waiting room or maybe in the consulting room. I think often we miss things like a neurodivergent person may have, I don't know, if they've had to catch the bus to even attend the appointment, they've already had a barrage of sensory input that might be overwhelming. And so even before they get to the appointment, they might be quite heightened. And when we experience sensory overload, the body can be very quick to enter a fight or flight response. So that means that even before getting to an appointment, we can be working with someone who's highly anxious, might be irritable, already overwhelmed. And then when we then layer on top of that things like difficulties with unfamiliar environments, being asked a whole lot of questions about symptoms that require a whole lot of interoceptive awareness, we can be dealing with someone who's really, really struggling. And so the environment becomes incredibly overwhelming very quickly. And just as a result of some of those sensory processing difficulties that we see amongst neurodivergents, it's really common to see people who have increased levels of anxiety, increased phobias around medical procedures, or bodily fluids, things like that, and also high levels of avoidance. Obviously, when we're highly anxious about something, avoidance seems like a lovely option. So something that can make things more challenging, but is also completely understandable when we understand that neurodivergents process sensory information differently than the neurotypicals. So what can we do about it? So managing sensory stimuli within our environment. So that might be checking in with someone to see whether the lighting's okay in the room, asking about temperature, things like that. Just asking about sensory preferences. I know there's some amazing dentists out there who will do things like, check in whether the mouthwash that they're using is something that is palatable to someone, or things like that, thinking about fragrances, things like that. If we're having longer appointments, providing movement breaks can be really important, particularly for clients who can get restless and have difficulty sitting still, so higher levels of energy. So that can simply be, asking them if they need a break, and it might be 5 minutes, and let them go off and come back. Or for some of my clients, for example, it might be that we do a walk and talk session rather than sitting in the office, because sitting still for an hour can be quite challenging. Providing access to fidgets, things to fiddle with, can be really helpful. Providing instructions before procedures, so that's just to prepare for sensory sensitivities, and helping the person, I guess, adjust to the prospect that they might be about to undergo something that is sensorily quite challenging. To tackle some of the issues around interoception, having prompts to describe symptoms. So this can be, a list of words that describe different types of pain, or it might be, so in my office, obviously, I'm doing a lot with emotions. So, having a list of emotions up on the wall, and I've got a pillow that's got a list of emotions and things on it, because I guess similar to physical symptoms, those difficulties with interoception can also manifest as difficulty describing emotion states as well. So just having those prompts around the place that neurodivergent people can draw on. So rather than having to generate this stuff from nothing, it's kind of okay, headaches. So headaches are a thing, or having a picture of a body or something, so that can sort of map through, okay, do you have any symptoms in this part of your body, in that part of your body? So there's just something to refer to. And revisiting symptoms then at follow-up. So as I said, it's not uncommon for me to encounter clients who deny having symptoms, and then having prompted them, they might come back a few weeks later and go, actually, I do have that thing I just didn't recognize. And that's when I describe myself as feeling crap or feeling not okay. Actually, I am dizzy at that time, or something else is going on that I didn't realize was going on. Social stories. So social stories can be are a tool that we often use with neurodivergent people, particularly younger people, but a lot of adults find them helpful as well. So it's just a little bit of information and pictures to describe what's about to happen. So as I mentioned, that might be sending out some pictures of the waiting room, a photo of the clinician that they're going to see, that kind of stuff. And also providing opportunities to familiarize themselves with equipment. So it might be just before you're about to do a procedure, just letting them have a look at things, or providing some of that information ahead of the appointment. And a common theme that's going to come out today is ensuring flexibility. So just acknowledging that things like movement breaks and things like that do require flexibility in how we work with our clients. So next up, another common barrier being cognitive processing differences. So one of the really big things that contribute to the differences in how neurodivergents experience the world is differences in how their cognitive processes happen. So some of the things, I guess, to take into account is intellectual ability. So it's really important to take that into account. So because neurodivergence often, I guess it gets assumed that there might be difficulties with intellect, and that can lead to people talking down to autistics or ADHDers. The flip side of that is there is a significant level of intellectual disability as well in amongst the neurodivergent population. So just recognizing that there can be assumptions that we make about people living who are neurodivergent, and I guess just calling ourselves into account on that, and taking the time to actually get to know someone rather than making assumptions based on a diagnosis that either someone is able or isn't able to do something. So the other thing that we really commonly see in neurodivergent populations is what we call scattered cognitive profiles. Scattered cognitive profiles is, I guess, a term used to describe different areas of intellect. And so when we do a cognitive assessment or an IQ assessment, we look at different areas of ability. It's not a universal construct that we're looking at. And so the standards for an IQ assessment are based on the neuromajority, so neurotypical populations, which means that the 4 or 5 domains, depending on how IQ is being assessed, are generally fall all in the mid-range. And then often what we see then with neurodivergence is you'll see the 4 or 5 different domains that we're looking at. We might see someone who's exceedingly high in spatial reasoning, so making sense of spatial information, but then have a score that's really, really below average in, say, processing speed or working memory. And so this can, I guess, make it really, really challenging, I guess, to I guess, understand quickly how to work with someone, and can, I guess, contribute to some of those assumptions that we see being made about the intellectual ability of neurodivergent people. So just being, I guess, mindful that because someone, for example, may struggle to answer a question, which might be reflective of having difficulties with processing speed, it doesn't actually necessarily mean that they have a low intellectual ability. And so just being mindful again of not using language that's below or above someone's intellectual ability, and taking into account things like processing speed and working memory as things that might impact how clients engage. Some of the other differences that we see in terms of cognition for neurodivergence is monotropic interest. So this is a tendency to focus quite intensely on particular interests, or to particularly, I guess, with ADHDers, a tendency to hyperfocus. The reason, I guess, that I've included this, because it's not necessarily something that's explicitly or inherently obvious, is that it's not uncommon for neurodivergence to develop these really strong interests around whatever is going on for them physically or something like that. And so it's pretty common to then encounter someone who has not even heard of POTS 6 months ago, to someone who's then become completely obsessed with it and then gone and read a million articles on it and have a wealth of knowledge. And so that can be quite confronting, particularly when we're used to being people, used to having a lot of information, to then be confronted with a patient who sat there and has actually read just about all of the articles that we've read across a longer period of time. Reduced processing speed. So I mentioned that briefly in terms of scattered profiles. Reduced processing speed is one of the cognitive processing differences that is really common amongst both autistics and ADHDers, and really just reflects a need to the fact that it takes longer to process information. So just something to be mindful of. And the last one being top-down versus bottom-up processing. So as a vague way of explaining it, so top-down processors are people who think about the big picture and then struggle with the small details. So that tends to be what we see in a lot of ADHDers. And then bottom-up processors tend to be the autistics who collect little bits of information and they build the picture from the bottom up. So there are pros and cons of these different ways of processing information. So the top-down thinkers tend to have difficulty with the fine details of things, whereas bottom-up processors tend to need a whole lot of information in order to be able to make sense of what's happening. So talking conceptually to bottom-up thinkers may not be a helpful way to approach working with them, versus top-down thinkers giving them a whole lot of little bits of information is not likely to be lead to a successful interaction. So just being mindful of those different processing styles and trying to adapt your approach to be mindful of it. So just some strategies to manage the cognitive processing differences that neurodivergent people may present with. So again, using clear and simple language and checking in then for understanding. So sometimes it's just about asking them. So asking them to repeat back or explain, what they took out of what you said, just to make sure that they have understood what's going on. Avoiding assumptions about cognitive abilities. So this, a lot of this takes really getting to know someone to be able to be able to, I guess, engage with them at their in a way that reflects their cognitive abilities and that's going to work with what works for them. Being mindful of assumptions and avoiding infantilization. So the assumption that because someone's neurodivergent that they're not going to understand. Ensuring treatment plans are personalized, so working with individual strengths and working with what works for the patient. Sometimes that means thinking quite laterally about how we're doing things and trying to, I guess, problem solve collaboratively to make sure that what we're presenting as a treatment plan is something that's actually going to work for the individual. So engaging formal and informal networks. So some of that's just about information gathering. Don't be afraid, provided obviously it's okay with the client, to connect with other networks of the client, because often other people who have already worked with the client or the patient will have, nutted some of this stuff out and will have some really helpful strategies to be able to articulate what works, what doesn't work for this person, and it can save you a fair bit of time in terms of trying to figure that out and adjust your approach. Flexibility with appointment scheduling. So that might be for someone who's got ADHD, that they might struggle to last an appointment that's an hour. So it might mean that we need to shorten appointments. conversely, for someone who's struggling with processing speed, it might mean that we need to actually give longer appointments to allow time to process the information and be able to effectively get through everything. So visual supports and what is supposed to say multimodal information, so offering different ways of accessing information. So be that YouTube clips, be it TikToks, be it pamphlets, just having different ways that you can present the information to clients to make it accessible for the different ways that they process information. Having opportunities for follow-up and questions, which is similar to, I guess, the communication, is just making sure that there's space to revisit things. And as clinicians, ensuring that we're engaging in reflective practice and monitoring for countertransference, which is really just about checking in with ourselves and checking in what assumptions we're making about someone, and just making sure that we're giving that client the opportunity to be themselves, and that we're not projecting our own stuff onto them. So following on from cognitive processing differences, so we've got executive functioning, which is a big part of the difficulties that ADHDers experience. So it covers a whole range of different areas. It's a term that gets floated around a lot, but my experience is that not many people actually know what it means. So executive functioning involves a whole lot of higher organizational skills. It's critical for organization, prioritizing, sustaining attention, regulating emotions, and all sorts of things. Just listed here are a number of domains, I guess, that are associated with executive functioning. And this often requires a lot of scaffolding for neurodivergent people. It can result in a whole range of difficulties, so from scheduling appointments to articulating symptoms, following instructions, remembering to take medications, completing treatment plans, through to things like just completing the paperwork, and things like that. So executive functioning is used for so much in our everyday life, and can be a huge challenge for neurodivergent people. So just putting in some structures around that, and a lot of these, I guess, recommendations are repeats of things that have been on previous slides. And so again, it's using strategies like providing written instructions for treatment so that, a client can refer back to it after the fact. Keeping things like ensuring consistency with appointments. So, certainly for me, and I'm sure for a lot of other clinicians, I find that my attendance rate is a lot higher when clients have a regular 2 o'clock on a Thursday appointment or whatever it is, rather than things that are bouncing around all over the place. And just providing scaffolding around things like treatment plans and things like that. So working collaboratively with the patient to try and problem solve those niggly challenges that come about because of executive functioning difficulties. So it might be putting in place things like medication charts or checklists, or some setting alarms. It's going to vary from different for different patients. And so, as I said, just working collaboratively with the patient in a non-judgmental way to just go, okay, so what's going to work for you, and rolling with that. And so just lastly, in terms of, I guess, thinking about barriers, is just thinking about, I guess, the financial status of neurodivergent people. So neurodivergent people face an enormous number of barriers to employment. And I guess it's also important to recognise that where you're working with an autistic or ADHD adult, if they've got kids, they've likely got neurodivergent kids, or vice versa. So if you're working with a neurodivergent child, you're likely to be also working with a neurodivergent family. And so just recognising that there can be enormous financial implications on that. And so just thinking about that in terms of making recommendations and booking appointments for clients. So doing things like clearly communicating fee schedules, rebates, and things like that, so that they can appropriately, I guess, plan for appointments. Supporting clients to be aware of rebates and funding opportunities or funding sources, being mindful of over-servicing, not just giving an appointment because just thinking about that, that extra appointment might actually be the difference between that person being able to eat that week and not being able to eat that week. Obviously, for a lot of service providers, we're operating in private practice, so things like bulk billing or reduced cost services can be challenging, but where possible, we're actually thinking about them as options, offering sliding fee scales, things like that, can be really helpful just in terms of ensuring access to supports. And things as well, like thinking about the costs of things like just transport to attend appointments and things like that can actually be a significant cost. And so for a healthcare provider who might be in paid employment, might not think too much about, a bus fare or something like that. But something like that can actually be really difficult to find. And I guess just the last one as well, being thinking about like when we're making recommendations around medications or lifestyle modifications, actually thinking about how accessible they are to the client and thinking about whether or not that there are alternatives to those recommendations. And I think probably amongst my clients, I often hear there's recommendations of certain electrolyte products and things like that, which I'm sure are amazing, but are so far outside of the reach of so many of my clients that, thinking about options that might be more accessible around salt intake and things like that is really important. So that just covers off, I guess, all of some of the challenges that neurodivergent people can face in terms of accessing healthcare services. Probably just the last point that I wanted to highlight is the importance of screening. So I'm assuming that there's a mix of people in the audience, some who are working predominantly with neurodivergent populations and some who are, I guess their work is more focused on the physical health, the POTS and the dysautonomia. But just thinking about what screening we're doing in those settings and just making sure that that when we're working with these populations that we're actually screening for either neurodivergence or dysautonomia, recognizing that without the knowledge of that stuff, there can be a whole lot of barriers that are impacting access to healthcare. That are, I guess, going unspoken and unrecognised. And so with more knowledge about what's going on for people, we're better able to support them and they're better able to advocate for what they need in terms of supports. So that's all that I've got for today. I've just got some space for questions if anyone has any questions.
Thanks so much, Cary. That was very comprehensive and incredibly informative. And we really appreciate your insights this evening. There are a few questions that have come through via the Q&A. So we've had one from a parent of somebody whose child has autism and ADHD, and some of the difficulties around attending appointments, particularly when they reach the adult stage. So once they're 18 or above, but still may not feel confident in expressing their symptoms or what they've been experiencing, and wanting the parent to speak on their behalf, but healthcare professionals not really wanting that to happen, and trying to, looking to get that information directly from the patient themselves. Is there any formal channels to work around that? So, for example, a power of attorney or something that would allow a parent to speak on behalf of their child without going through that, in the consult itself.
Yeah. So I guess in a situation like that, I guess the way I would approach that, and I'm not sure how it operates in other clinics, I guess something to be mindful of is that there can be, I guess, a propensity for some people to be in a situation where there is that tendency to, I guess, speak for a patient who's able to advocate for themselves. And so it can be a difficult balance as a clinician to try and gauge what's going on. I guess typically the way that I would approach that in a session with a client is, well, often it will just be a momentary thing in the waiting room for me. It's do you want your mum, dad, whoever is there, do you want them to come in? And my sense generally as a clinician is you can get a pretty clear picture fairly quickly, just by reading, I guess, the dynamic between how quickly and how responsive the client or patient is as to whether or not that's okay. Generally in my setting, and I'm not sure about other settings, but I would often just be asking for an 18-year-old or any other adult to be signing a consent to exchange or release information, which is just a document, which I imagine is the same across a lot of private practices. Yeah,
I think that is common across a lot of private practices. I'm not aware that there's a specific power of attorney that would allow a parent to do that. But I think engaging with the clinician on the day could be one way of probably addressing that in the moment in the consult.
Yeah, and certainly doing things like, sometimes it will be, if it's ahead of time, getting the client, if they're not comfortable talking, even to email ahead of time and just saying, can I bring mum into the appointment or something like that, which then I guess creates that awareness that there's a sense of autonomy, that this is a young person who's genuinely wanting their parents involved. And finding, I guess, a way that the young person can be empowered to have that voice without necessarily having to rely on spoken communication.
Yeah, and I can't emphasize enough the value of those patient-reported outcome measures that you referred to in the latter part of your presentation, just to really provide some information before you even get to the clinic appointment about what sort of symptoms this person is experiencing or what particular challenges they're experiencing. I just think they're really invaluable within the clinical setting. In helping to alleviate some of the anxiety that the consults can create. Another question: how do you know if someone is top-down or bottom-up processing?
So it can be that can be challenging when you're not super familiar with what the two different processing styles are like. And I appreciate that I actually skipped over some of this information fairly quickly because I was mindful of time. So often what you will see with a top-down processor is that if you give them lots of information, they will get lost. So there's someone who will generally deal better with concepts and big ideas, and respond well when you provide them more with concepts rather than specific instructions, compared to a bottom-up processor. So I'm trying to think of an example of a top-down processor might respond really well to a vague comment of increase your physical activity. This is just a very off the top of my head example. Whereas a bottom-up processor would be someone who would be looking for more information. So they would be going, okay, well, how much exercise do I need to do? What does that look like? Do I need to be doing cardio, or do I need to be doing something else? So that kind of thing. So you'd be looking for, I guess, those common themes in how they're responding to the information you're providing. So a top-down processor, if you give them lots of instructions, will generally get lost. A bottom-up processor, if you give them a broad concept, they'll probably get paralyzed because they have no idea what you want them to do. So just looking out for those little cues, I guess, in how they're responding to what you're presenting.
Yeah. Somebody has asked for an explanation of engaging with formal and informal support networks, if you wouldn't mind covering that again.
Yes, and apologies, that was another thing that I am aware that I skipped over. So when I refer to formal support networks, I'm talking about, it might be allied health professionals, it might be support workers, it might be pretty much any support that is paid to be in someone's life. And then informal supports being family, friends, anyone who's in the person's life because they know the person and they've got a friend or family relationship with them. So just looking for opportunities if the client or patient is struggling to engage, to if the patient's open to it, being able to access those support networks, and either work collaboratively with them or get ideas on how might be advantageous to actually work effectively with that person, because no doubt along the way they've learned what works and what doesn't work.
Absolutely, thank you. Okay, somebody has asked if you are able to comment on the extent of the impact of trauma symptoms on exacerbating POTS, so specifically related to PTSD.
I feel like I need to do a whole nother webinar on
we'll
that.
have you back.
Yeah. So yes, there is a relationship, is how I'm going to put it simply, and a huge relationship between, it's the whole premise of what health psychology is the relationship between psychological health and the impact of things like anxiety on exacerbating POTS symptoms, and that relationship is enormous. And obviously POTS being a condition where there's that impacts the sympathetic and the parasympathetic nervous system. When we experience then things like trauma, there's a big impact on that. But I feel like I'm about to go on a thesis that I probably don't have time to cover right now.
Yes, I think it's fair to say that there's an association. Some people describe it as a trigger too for symptom onset. So particularly, symptoms related to their POTS. But certainly, we know with POTS and autonomic dysfunction that symptoms can fluctuate over time, and trauma, stress, anxiety, emotional disturbance can exacerbate POTS symptoms, much like other things may exacerbate POTS symptoms too, like viruses or being unwell with something else. So it's a something else that may exacerbate POTS symptoms. But I think you're right, Cary. We could spend another webinar discussing that. And our final question for this evening, we have run a little bit over time, but are you aware of any official, formal or legislative disability accommodations that can be requested by neurodivergent adults when accessing healthcare and other services in Australia?
So just looking at your question there, I see that the broader question references the Disability Discrimination Act, which I would say obviously is the same, like the Disability Discrimination Act is not exclusive to schools. It's something that is broadly applicable. And I guess the challenge, and this is a challenge that we see in schools as well, is while the Disability Discrimination Act exists and we theoretically, based on that legislation, should not be discriminating against people, the reality that we know is that this stuff happens. And I wish that I could offer a fantastic, answer to this. And I think that, I guess the answer to this is quite multifaceted, in that in an idealistic society, the Disability Discrimination Act would do what it is intended to do and protect discrimination, and would provide avenues for self-advocacy and for people to step up and articulate what they need. Unfortunately, I guess because of the complex systems in which we operate, it's not always as straightforward as that. And so I guess my tendency, what I generally recommend to people is to actually seek out services that are known to be accessible to neurodivergent people, which unfortunately feels like it's putting the responsibility back onto the patient, but is an unfortunate reality, I guess, of the systems that we deal with, and the complexity of those systems and the powers that are at play in those systems.
Yeah, absolutely. I think our healthcare system has a long way to go, but raising awareness is important. And I think your webinar this evening has helped to increase awareness and understanding greatly, Cary. So thank you very much for joining us this evening to present this webinar. It has been recorded. It will be sent out to all attendees, because there was a wealth of wonderful information that I'm sure people will want to revisit. Please keep an eye out in your email for the evaluation form for this evening's webinar. And you'll also find some information in that email about our next webinar, that will be held on the 25th of July with Dr. Eva Nagy, and that will be changing tack a little bit. We'll be focusing on mast cell activation syndrome and breast implant illness. So it should be a very interesting webinar, and I hope that you will all be able to join us then. Thank you and good night.
Thanks, Celine.
Thanks, Cary.